Assalamu alaikum. The short clinical station day. First scenario, an 87 years old woman who presented with a short of breath. Please do a respiratory examination. Here you go, Dr. Muhammad.
Okay. I will hello the examiners, then go to the wall, check the case instruction, then I will go to the patient. I will hello him and take a permission. I am Dr. Muhammad. I am candidate basis today. I will examine you. I will examine your chest. I will tap and put my stethoscope. If any pain, tell me. Okay, it's okay for you?
Yes.
Any pain now?
No.
Okay, I will take one. I will in the foot of the patient, and I will take a look surrounding any cup, sputum cup or auto cylinder
No.
around. Okay, how is the patient breathing? Palm breathing or dyspneic?
No.
Okay, I will ask the patient to take a deep breath.
Yes. Yeah.
Any
What is that?
asymmetry?
Yes, a significant asymmetry on the left.
Okay, I will tell him to take a good cough.
Usual cough. It's not productive.
Okay, I will go to the patient and start by his hand. I will tell him extend his hand. I will check any clubbing, any nicotine staining, any cyanosis,
No cyanosis, no clubbing, no tar staining.
any flaps,
No, no flap.
any atrophied muscle of the hand.
Sorry?
Muscles of the hand is okay.
No, wasting of the bilateral hands and muscles, particularly distally.
I will check his pulse, check the breathing rate, how much?
Breathing rate 20 beats per minute, and the pulse is 90 beats per minute, regular with good volume.
I will ask for saturation now.
Normal.
I will check his GVB.
Yeah, please do it.
Okay, GVB, I will ask to breathe in his abdomen. It is increased or normal?
Okay. One second.
Normal.
Normal GPB, yes.
Okay, I will check behind his hand in its axilla any scar for lymph node or biopsy.
In the axilla, no scars.
I will check any pallor, any cyanosis.
Pallor, but no sinuses.
There is pallor.
Pallor, yes.
Any jaundice.
No jaundice.
Okay, I will check. I will check lymph node also supraclavicular and
Negative lymph nodes.
I will check for B2, loud B2 and apex in place.
Apex is normal. B2 is normal. Like normal second heart sound.
Yeah, I will ask the patient to sit and start examination from the back. Started
Okay.
by expansion. How's expansion? On the right side decreased, on the left side decreased.
So chest expansion is decreased globally, but more marked on the right side.
Right or left? Because the expansion was in the left
sorry,
side.
pardon, the left. The left.
I will tap percussion. How's percussion note?
Percussion note. Percussion note resonant. I would say like resonant. Okay. The percussion note was, sorry, one sec. This is a patient that I examined today. The percussion note was, okay. The percussion note was resonant on the right and dull on the superior or the upper zone of the left. Sorry, did I say it right? Resonant on the right and the left side, the upper half is dull and the lower half is resonant.
Yeah, and only dull on the left upper side,
Yes.
right?
Yes.
Otherwise, resonant, right?
Otherwise, resonance, yes.
I will here by stethoscope upper, mid, and lower zone. How is the left upper zone?
Sorry, what did you want to hear?
I will here auscultate the
Normal breathing sound is throughout the lung, but decreased air entry on the left upper zone.
okay. Any bronchial breathing there?
No air entry, no bronchial breathing, no wheeze, no crepitation elsewhere.
It is Dallistoni or
1 minute left.
Dallistoni or
I would say just dull.
just that? Okay. Vocal resonance, I will tell him 44.
So vocal resonance is normal on the right side, but it is decreased on the left upper zone.
What about the trach left shifted to left side?
Trachea, you mean?
Yes.
No, centralized.
Centralized. Any tug? Tracheal tug?
No tracheal tug.
Okay. I will do fast the expansion and percussion and auscultation with the same on the in front.
Okay.
Then I will check the lower limb, inner lower limb edema.
No lower limb edema.
What about the face of the muscle? Patient looked cachectic or normal weight?
No, the patient looked not cachectic. The patient looked sarcopenic.
Okay.
Okay, time is up. The examiner questions.
Could you please present this case to me?
By examining this gentleman, we have
She's a lady.
a female. Okay, female, 80-year-old, looks calm breathing on rest. By examination, and there is no surrounding oxygen cylinder or any spinal cup. By examination, there is a decreased expansion generally more in the left side and mainly in the left upper zone with decreased entry and dull in percussion note and vocal resonance also is decreased. Trachea is central and no tracheal tug, no sign of heart failure, no sign of pulmonary hypertension or heart failure or pulmonary.
And what's your differential diagnosis for this case?
My differential diagnosis, and patient is bad also. My differential diagnosis.
I'm really sorry that the voice is all breaking up. I could hardly hear you.
Hello, سامعني كده؟
Yes.
My differential diagnosis in view of patient's pallor and sarcopenia and this medical zone. I will put my differential diagnosis patient COPD and
I'm not sure if Dr. Dabassim is able to hear, but honestly, I'm unable to hear.
There's some breakings, Dr. Muhammad, if you can adjust your internet.
Can I get out and come back to Dr. Basim, okay? We'll just
Okay. We'll put the timer.
Dr. Basim.
Yes,
Okay,
this is
here you
better.
go.
My differential diagnosis, a COPD patient complicated by or obstructive disease complicated by left upper zone collapse, cancer or mass, cancer or mass.
Could you please give me 3 top differential diagnoses and tell me why yes and why no? Or why more likely and why less likely?
Okay. First diagnosis, there is collapse and cancer. Cancer complicated by collapse. This is my first diagnosis.
Don't complicate things. Just give me one diagnosis. So the first one is collapse. Why do you think it is lung collapse?
We have decreased their entry, dull in percussion, decreased vocal resonance, no sign.
Fantastic. That's not fantastic. That's it. What is your second differential?
Also, cancer in view of the patient have atrophied muscle sarcopenia. So patient is she has alarm sign of sinister symptoms.
Hmm.
Okay.
So if you expect there is a mass, where do you expect the mass will be?
In the upper zone, it will be pancreas tumor, especially if the patient heavy smoker.
Okay. So
And
if
there
there is
is
a mass in the left upper, do you
yes,
expect the vocal resonance and the vocal frequency to be increased or decreased?
with mass, it will increase.
Exactly. So this is my second differential diagnosis is a mass in the left upper zone. This is what goes with this is the sarcopenic picture of the patient. However, it's less likely because the vocal frequency was reduced on that side. Great. What's your third differential diagnosis?
Localized effusion.
Okay.
Okay. We have also, as a background, the patient has obstructive lung disease in view of his generalized hyperresonance and
No, the
decreased
patient has had resonance, not hyperresonance.
resonance. Okay. Okay. So
Yeah.
I will remove this differential. Uh,
If I told you that the patient has had a scar that you did not manage to inspect, and the scar was in the posterior lateral side of the left chest, how would that change your differential diagnosis?
will be lobectomy, upper lobe lobectomy,
Or,
pneumonectomy.
okay, and why? What do you think? Is it lobectomy or pneumonectomy, and why?
Uh, in view of the patient, her entry in the upper zone only decreased and the other, okay, it will be lobectomy more than pneumonectomy.
Exactly, and the trachea is central.
And yes,
Okay, so your differential diagnosis for this case is lobectomy, pneumonectomy, collapse. These are the top differential diagnoses. Okay, and how would you investigate this lady?
I will investigate apart from basic investigation, besides the patient, I will saturation and EPG and pulmonary function, pulmonary function test. Then I will ask for chest X-ray and CT to confirm the diagnosis. And apart from basic CBC for anemia, for sign of infection, ASR, CRB for inflammatory response. I will send maybe patient later on need bronchoscopy or to rule out any obstructive causes of the collapse. Or if the patient have bronchopenetrans as a long-term complication of sorry for transplant. There is sorry, this is not potential.
Sorry, what did you say about the transplant?
I am telling about bronchoscopy. Patient
Bronch-
may need bronchoscopy to rule out any obstructive causes for the collapse, foreign body or sputum or other complication of after
Yeah,
lobectomy.
all that. Yeah.
Uh,
And how would you manage this lady?
according if patient have respiratory distress and desetting, I will start by ABCD approach. I will start by maintaining airway and breathing, maintain saturation, may up to I need intubation, may need bronchoscopy to remove the cause of the collapse, and sharing the multidisciplinary team of respiratory, pulmonology, and uh, social and occupational health worker.
Hello.
Yes, we can hear you, Dr. Ines. I think the problem from Dr. Muhammad's side.
All right. So can I just say something till Muhammad is back so
Yes,
that
please.
we're using the time for good. So
عاملين الهناك بتاع المنصور ده جايب 1000.
Yes,
I think
Dr.
the
Inas.
case was like a spot
Yeah, here you go.
diagnosis.
Yeah.
I think the case, this case I've seen today, and it was spot diagnosis from the inspection. She did have a very large posterior lateral, a very long posterior lateral scar. It was literally extending from her upper scapula down to her, literally the spleen. And apparently she has had a lobectomy for an old TB. And I'm quite concerned that it could be a thoracoplasty as well, because there's a big asymmetry between the right and the left. So I was not very sure if they took out a few ribs or it was just an incision. But my top differential was for her is either like lobectomy, thoracoplasty, or like pneumonectomy. And to be honest, she came in with a bacterial infection for another reason. Like she came in with UTI. That was a completely like different story. And yeah,
Yes, Dr. Inas. Continue.
no, that's it. That's it. I just wanted to
Yeah.
say that it's all about the scar. You see the scar,
Yeah.
and then you correlate everything that you see based on the scar. And the sarcopenia picture for this patient does not necessarily mean cancer, because, for example, a lot of patients with COPD, they are sarcopenic because it's a high metabolic status where they put a lot of effort breathing in and breathing out, and they end up being sarcopenic. So I would not put my differential cancer purely as per the sarcopenia. I would mention that the patient is sarcopenic by my differential is 1, 2, 3. I would need to rule out cancer, but I would not purely mention cancer just because of the sarcopenia.
Better, دكتورة Ines, if there is a scar, even you can bring a picture, very faint picture. يعني it will be make a difference, because sometimes
Oh,
I
I see.
will forget
No.
to ask.
You asked me about like
I ask
asymmetry.
about any scar for biopsy, any scar there. I don't.
No, you asked me about any scars in the axilla, and I was clear. But it's all right. In clinical life, you would have picked it up, but just because it was in the back, sometimes some people forget to inspect in the back. So this
Right.
is yeah, but you've done really well, and you got the differential diagnosis and the management. All was good. I just wanna. I know that this is not like a real exam, but when you introduce yourself at the start, just make it as brief as possible. Like, my name is Dr. Alalul. I am one of the doctors, full stop. Don't say I'm one of the PACES 3 candidates. No, I am one of the doctors, full stop. I have been asked to examine your chest. Is that all right? Do you have any pain? No. If I caused any pain or discomfort, please let me know. Yes, you will waste maybe 20 seconds, but I've been told by PACES examiners that they know who's going to pace or fail from the first 30 seconds. So if you make that impression, and then when you go to the chest, you can make it a bit quicker, particularly if you knew what's wrong. Do you understand what I'm saying?
Yes, good comment, really.
And honestly, I've been practicing for 1 month, and I've like just yesterday someone told me this, and since yesterday I've been practicing this way, and I think it makes a big difference. Like I start standing in front of the mirror, and my exam is in the afternoon, so like, good afternoon, I am this I'm gonna do, and it does make a difference, I felt. And the other thing, Muhammad, I'm not sure what sequence you go through the examination, but usually I will test the trachea whenever I am in the neck. So I test for a JVP, then test the trachea, then examine for the cervical lymphadenopathy. And when you examine for the cervical lymphadenopathy, you would likely examine from the back. And at this point, while you're examining, you have a look to the back as well to see if any scars. And like you, I start usually from the back, then I do the front just to show off. I do not really get many signs from the back. Particularly this lady, I think today when I compared her examination from the front and examination from the back, I think if I relied on the examination from the front, I would not have get it right because of the cardiac presence on the left. It change your signs, particularly it will change the vocal resonance and vocal fremitus, etc. But on the left, you're more likely to get it right. And the last thing is about management. Maybe you've mentioned that, but I'm really sorry. The voice was breaking. Sometimes you don't know how much left in your 4 minutes time to discuss. As soon as they say management, you would say multidisciplinary team. And then you start talking. Because that might be the last 10 seconds in your exam, but it could be that you have 1 minute left. You can talk for another 1 minute.
Perfect.
Amelia?
Thank you, Dr. Inas. Any other comment?
No, that's it. Thank you.
Yeah, I will start from the end. It's really very precious advice. Whenever he asks you what the management plan, start with multidisciplinary team. This is always my advice. Why? Because you don't know what the rest of the time for the examiner he will ask you. Maybe this is the last question. And be sure that they are trying always to cover all skills, differential diagnosis, the finding, and the investigation and management plan. They are trying to do all of them in 4 minutes. Please try to be short as much as you can. Whenever you are presenting, don't waste the time. Always start with the positive finding that can give you a clue or give the examiner a clue that you get the case. So I have this in this patient, for example, limited expansion on the right side. The percussion node is resonant or dull in the right apical side. And on auscultation, there is bronchial breathing, for example, as well as for the vocal resonance increase in the right apical side. Then you can present the other finding, which is not helping to give a diagnosis. He might stop you, doctor. What do you think the differential or what do you think the case is? My case or these features suggestive of, for example, apical mass or apical lung consolidation or TB or cancer, whatever you want to mention, he will know that you are going systematic and giving good differential, which is very sensible to your case. I think, yeah, Dr. Muhammad got the differential well, but the case as a TB, it's very common to mention TB in the elderly patients. Yes, it's one of the differential of apical mass or apical dullness, along with the consolidation, collapse, TB, as well as the cancer at the end. Or maybe in the top, if you have lymph node, for example, or wasting, or some of the sinister sign, like loss of or cachexia of the muscle of the hand or cachexia in the face, whatever of the finding you have there, you can mention. The chest scenario or the respiratory system examination station, one of the easiest one, if you get the clue. And if you have a scar, you will be more lucky and lucky. Just mention thoracotomy scar, and he will guide you through the question. What do you think the cause of the thoracotomy scar? What do you think the differential? And so on. Okay. The investigation as well. Most of the chest will be the same investigation, starting from bedside ABGs, pulse oximetry, spirometry. He will ask you the same question for spirometry. What do you think the finding in the spirometry? You will mention either obstructive or restrictive according to the underlying pathology. Then the management plan will be also almost same, or the investigation, other investigation, you can do sputum culture, bronchoscopy, CT, chest X-ray, whatever the case. So for example, if you have infection, you suspect apical fibrosis, you can start with chest X-ray as a simple test. If not conclusive, and you want to diagnose more advanced, will be high resolution CT chest. If you suspect cancer, So you can say CT, chest with contrast. If you have a mass or biopsy you want to take, you can do bronchoscopy with biopsy. According to the level, either peripheral, you can do CT guided, or bronchial, you can do ultrasound guided or bronchoscopy guided. In, okay. The management plan, again, it will depend on the cause. They will ask you what to do. So you'll start with multidisciplinary team. You are not the only one in the team. You have other members, pulmonologists, thoracic surgery, for example, along with the ID, infectious disease, if you have suspicion, oncology, and the treatment of the underlying cause, like anti-TB if you have TB, if you have a cancer, staging after the differential or differentiating the type of cancer. So it's a very easy case and station. If you start in the systematic way, if you have a clue, you can mention it. Particularly the breathing sound. Is it obstructive? Is it crackles? And does the crackle relieve or change by cough? Or is it coarse? Here, I think Dr. Inas put it as a case for differential since the age is high or elderly, 80 plus. And I think before there was no treatment for TB. So maybe the patient is having TB with or without lobectomy. Some of them, by the way, they have the fibrotic lung till this age without any surgery. Some of them, maybe they have the surgery according to the distracted lung. All right. Any comment or adding point, Dr. Inas?
Oh, that's it. Thank you.
Yeah, it's a good training, Dr. Muhammad, to know. And by the way, in the exam, definitely you will have the scar. You will never miss the scar in the exam. It will be clear. Just point to it, even if you will not mention it in the presentation. By pointing on it, the examiner will know that you catch it. Here, while we are doing it as online session, of course, either there is no picture, you might miss because no picture, but in the exam, believe me, you will do it and you will catch the scar.
Well, she is right, Dr. Inet. Sometimes really the scar too old, yeah, too much time away. Sometimes very hand skill surgeon, especially in female, you can miss if it is يعني very hidden
Under the
and
breast, yeah, under the breast.
yes.
Well, I'm telling you, I missed a lot of
we
scars
have missed it.
in
We
white
have missed
people,
it.
particularly.
We have missed it before, but at least in our sessions we can bring one faint and one difficult to see like this to help the candidate. And yes, we should ask about the scars, تمام, frankly. The other thing, as you mentioned, Dr. Bassem, once you put your hand, I remember my case and cardio. You remember that case, Dr. Bassem? It
Yes,
was hairy and very faint scar.
yes, yes.
If we didn't hear the click and the patient has thrombose in the click or anything in the click, we will miss it. But the examiner, once he see you, you point your hand and he will know that you catch it. The other thing, uh, about the yes, in my sequel in the examination, really the same my mistake in examination. And they mentioned that I am misorganized because I went back before doing the trick and the tuck, and came back again after checking the back because I feel the time is passing. So I hurried to check the back to catch the signs and came back to the trick, and I missed the lymph node. At this time, he write for me in the feedback, he misorganized or unorganized examination. So
Can I just can I just ask a question for my learning? Do you start the chest exam by feeling the apex beat?
yes,
Okay, I didn't know that actually.
No, I asked you about the apex
Yeah,
and
but I know. Do you normally do this? Is it the right way to do it? Because usually I do this at the very end if I have time.
what is right when you have the you suspect from the cough that he has with cough and you go to the bronchiectasis and the cartagnar and this, better to it early because it can guide you even by stethoscope. If it is right side, خلاص, you catch the diagnosis from the beginning, from his cough and the apex. But this case, once you told me the cough is okay, I should leave it at the end after I finishing back and trach and lymph node and the back. From the hand, as we started, this I think this is good, Dr. Basim. Start from the hand, go to the. I have one case before. I have one case before. The only clue. He have a scar in his small, very small scar in his axilla. He had take some lymph node. Otherwise, you do lymph node anterior axillary submental everywhere, nothing. Only have a small scar. If you didn't execute the axilla well, you will. He has no other lymph node. Only he take the biopsy and remove the lymph node that he has. Then after that, خلاص, you catch this has suspicion of malignancy or like this, and on top of his old heavy smoker, and you give the diagnosis to the examiner. So really want the apex should be at the end when you have you are away from the wet cough and the bronchiectasis. But if from the beginning you have a wet cough, better to do it early. And the patient still he's 45 degree. You didn't make him sit to examine the back of the chest. After that, as you mentioned, from you go to the back, do the lymph node after you from hand and the lymph node axilla and the trach and the tug, and you go to back, complete lymph node and continue for the back. Then, if you have time, acting for the in front and go to the lower limb. This is, I think, Dr. Basim, this is the best, right?
If you allow me, I will just correct it again.
Yes. Oh.
Okay. The best way, believe me, it will look even more organized in this way. For me, I prefer to start with the leg as you did. Step back and step back backward and ask the patient to cough and so on. Breathe in and out deeply, and you can see the symmetry or asymmetry. And with the cough, you can know from the start if this cough is productive or just dry. Okay, next step, you will go to the patient hand. Finish the hand steps, the fingers, the flapping, the nicotine, the clubbing, whatever you will have. Then you will go up the respiratory rate and the pulse. Have a look only quickly. Then go to the face. As we know, the face for any palojaundice. And while you are standing now in front of the patient, he's in sitting or semi-sitting position. You saw the cyanosis, the mouth for cyanosis, and you are going down to the chest and the front of the neck. Now the time to examine the trachea. Sorry for this. It could be discomfort for you. Do the a tracheal examination and the tracheal tug. And now you are still in the front. Go to the apex beat and the parasternal heave for pulmonary hypertension sign. Why I'm saying that? Because you might catch it early. You might go to the back and you will not have the time to go to the front again if you couldn't find any of the clues in the back. So after that, you will stand behind the patient, right? You are preparing yourself to examine the chest from the back. Now this is the time to examine for the lymph node at the neck. Can I feel here all the grooves in the neck and auricular and cervical, whatever you want to do, and you become behind the patient now, right? Examining the lymph node. This is the time to examine the back as an inspection. Please sit forward, examine the inspection, palpation, percussion, auscultation. Finish the steps. Then this is the time to go again to the front to examine inspection, palpation, percussion, auscultation, if you have time. Most of the finding, as Dr. Muhammad, Dr. Inas agreed, it will be in the front.
In the
But
back.
sorry, at the back, yes. Yes, at the back. And in the front, if you have you will say the same finding. If not, you already got it from the back. This is the best way. Looks even organized. You are not going back and front and back and front. The examiner will think that you are disorganized. What he's doing, right? So you went like music one, front, chest, the back, the lymph node, the back full examination. Then you end up with the front examination of the chest. It's as a last the step, and thank the patient and go to the examiner. This is the best way. You will not forget any, and you will be also looking like very regular and systematic. It's not the matter of Cartagena only. It's even a matter of pulmonary hypertension complicating most of the pulmonary disease. You can find it by examining the heart as a quick examination, not full heart examination or full cardiac examination. It's only for the pulmonary hypertension, parasternal heave, loud P2. If you find them, you can mention them as a complication and means that this patient is having chronic lung disease. I hope it's clear for all. This is the best way how to do the chest examination in organized way.
Sorry, Dr. Basim, again, front, back, then leg, or again, the leg.
Okay, I will mention in summary quickly. You will start at the leg. Step backwards for the chest symmetry. Okay, and at the same time examine for lower limb edema. Sometimes also clubbing in the leg. You are still standing at the end of the bed, right? Now you will go to the patient while he is in semi-sitting position. Extend your hands, examine the hands for the finding of the hands, nicotine or clubbing or tremors or whatever. Then the pulse, the respiratory rate. Then you are going up to the face for any jaundice, any pallor in the in the eye, the mouth, cyanosis, any gum hypertrophy for medication, for example, opening the mouth and the tongue for central cyanosis. Then you are going down now in the face, right? After the mouth, the neck. The neck from the front for trachea. Trachea, is it defeated, shifted, central, and the tracheal tag at the same time. Take a deep breath in and out for tracheal tag. Then now you are standing in front of the patient or beside the patient in the front. You will ask him, still you are in front of the patient. You will ask him in the same sitting position. You will examine the cardiac apex and pulmonary hypertension signs, parasternal heave or loud P2. Like you are going from up, downwards. Okay? If you finish that, you will ask the patient to sit forward. Okay? Sit forward and you will be like behind him or beside him, but more behind him. And examine for the lymph nodes of the neck, cervical, auricular, and supraclavicular. Now you become behind the patient almost. So you will examine the chest examination, full chest examination from the back, inspection, percussion, palpation, percussion, auscultation. After finishing all these steps, go back to the front. The last step of the examination, inspection, palpation, percussion, auscultation. Thank the patient, cover him, and tell him to relax and present to the examiner. Okay? Clear now for all?
Yes, thank you.
Yeah, this is the most systematic one. And you look to the examiner, you are confident, you are not disorganized. And you can catch all the finding without missing anything. Even if you miss the auscultation in the front, it's not that much important, apart from the cardiac. So it's a matter of finding the cardiac finding in the front, not the respiratory ones. Okay, clear for all? And you do it initially, as I said, before chest examination. It's important to have pulmonary hypertension if it is there as a complication of chronic chronic lung disease. Okay. I hope it's clear for all. I think also we discussed 3 times how to do the approach. So we can now move to the next scenario if no one has a question. Is it clear for all? Okay, I hope so. If not clear, anyone can write in the chat box. Dr. Ines, you're ready to start?
Yes.
Yes. So you saw your scenario, I think.
Oh,
40
no.
years old,
Yeah.
male, complain difficulty walking.
Okay.
Yeah, here you go.
Oh, hello. I'm Dr. Alalul. I have been asked to examine your legs. Would that be all right?
Right.
Do you have any pain or discomfort?
Oh, I'm okay.
Okay, if I cause any pain or discomfort, please let me know. At the same time, I'll be washing my hands. If the patient is not exposed, I'll make sure the patient is exposed at least from the mid thighs downward. I'll tell the patient, completely ignore me. I'm just looking for any clues. I'm looking for any walking aids. I'm looking for any orthoses. I'm looking for any stick or Zimmer frame. And I'd like to have a look in the shoes of the patient to see if they have any support in their shoes. Any of this is positive?
Yes, he has a walking aid.
Walking aid. Okay. Okay. Then I'll move and inspect the legs. Any deformities, any scars, any wasting, any fasciculations?
No.
No. Okay. At this point, I'd ask the patient to walk for me if possible.
Examiner told you no.
Examiner, no. Okay, that's fine. Now I'd like to assess the patient's tone. I'll ask the patient to be floppy and I'll assess the tone at the knee joint and the ankle joint in both sides, and I'll assess for a clonus as well,
Yes, there is hypertonia.
bilaterally
Bilateral
with clonus.
with colonus, not clear colonus.
Okay, no clonus. Okay, now I'd like to assess the power at the hip flexion, hip extension, knee flexion, knee extension, plantar flexion, plantar dorsiflexion, and the big toe dorsiflexion.
Patient has weakness more distal than proximal.
Okay, okay, weakness distal than proximally. Okay, then I'd like to check the reflexes, the knee reflex and the ankle bilaterally, and if they low or reduced, I'd like to do the reinforcement or the potentiation, and I'd like to assess for Papniski both sides.
Knee absent, ankle jerky, plantar up.
Sorry, knee absent, ankle.
Ankle jerky, plantar up.
Yeah, the voice just goes when you say plantar. Plantar positive or negative? Extensor or
Plantar,
flex?
plantar up going.
Upgoing. So upgoing is abnormal. Okay. Sorry, what do you mean by the knee jerky? Sorry, the ankle jerky. Is it like hyper or hyper?
Hyper.
Hyper. Okay. Okay. And then, okay. The knee is absent. Can I do potentiation or reinforcement?
Absent.
Absent. Okay. Now I'd like to do the heel to shin bilaterally.
Heel to shin, okay, normal.
Normal. Now I'd like to test the sensation. I'll start by the pinprick and show the patient on the upper chest how does it feel. Then I'll do it using the dermatomes bilaterally and ask the patient to cover their eyes and let me know if they noticed any change. If it is to shout out yes, if it feels the same as the chest.
Right side, loose pinprick up to mid femur.
Sorry, right side loss of pinprick sensation up to what dermatome?
L2.
L2 and the left.
Good.
Okay, sorry. Did you say downward from the toe up to L4, L2, or just the L2 is lost?
Up to L2.
Okay, so from the toes till L2 is no sensation.
What again?
So on the right,
Only pinprick absent up to L2. يعني you will examine L4 L5 no up to L2.
I'm just trying to understand. Is it just the dermatome L2 is absent, or L2 and downward everything is absent?
No pinprick from L2 downward.
Okay, that makes sense now. Okay. Now I'd like to test it to see if there is any stocking kind of distribution. I'll start from the big toe and move it upward and ask the patient to let me know if there is when they start feeling it bilaterally.
Normal at the left side, but at the right side up to mid thigh. He can
Okay.
feel.
Okay, I'd like to do the same for the soft touch.
Same.
I'd like to test for joint position bilaterally.
1 minute left.
Absent on right side up to knee.
Up to the knee, and the vibration sensation.
Same.
Vibration sensation.
Sorry. And I told at left side. Okay, left side absent, joint and vibration up to knee. But right side, okay.
Okay, I think I'm a bit confused with the findings, but yeah, the vibration sensation, it was absent on the left up to the knee.
Again, Doctora, right side lost anterior column, left side absent posterior column.
Okay, right side absent anterior column, which means the pinprick is lost. The left side posterior column. Okay, that's fine. And so on the left, you've lost the joint position and the vibration sensation is lost.
Yes.
Okay, I'd like to have a look in the back if there is any scars.
No.
No scars. Okay. Okay. I just want to organize my thoughts. Okay. So you did say the tone is increased bilaterally and then distal weakness. Does the patient have any deformities of the foot, like piscavis or hammering of the toes?
No.
Okay. And then the coordination was fine. Reflexes reduced at the ankle, at the knee, but hyper reflex from the knee downward. And the sensation,
Reflexes lost knee.
lost knee.
Exaggerated ankle bilateral.
Okay.
منو؟ ماله؟
Okay. I just want 30 minutes to organize my thoughts about this.
You can start by the lesion. What is the lesion and start to go on the differential.
Okay, you can collect your thoughts, Dr.
Yeah.
Ines, then
Yeah.
start presentation. Whenever you're ready, let me know.
Have this chance, yeah, Dr. Bassem, in exam?
No, of course. But because there is some confusion, I give you some time. But in the exam,
No,
not
I am telling. We hope they give us 1 minute to collect.
no. No doubt. They will not give you this chance because they have time to finish before the ring.
Yes, he's waiting the ring. Once the ring is there, he will be on your.
Exactly. Yeah. Whenever he ring the bell, go
Yes.
in, start. Whenever he ring, the examiner question will start. Once he ring again the bell, the examiner question finish, move outside, and so on. Trinas 1 minute, not 1 hour.
Okay. So I examined the lower limb of this patient. On general inspection, he has had no wasting, no fasciculation, no joint deformities. The tone was hypertonia bilaterally, and in terms of the power, he has had global weakness in both limbs, but more distally than proximally. Coordination was intact. He has had absent knee reflex, but the ankle was preserved, and Papniski showed Papniski sign was positive. When I examined for the sensation, so pinprick and soft touch was decreased in the right leg up to the L2 dermatome, and the vibration and the joint position sensation was decreased on the left leg up to the knee joint. To complete my examination, I'd like to assess the patient's gait, examine the upper limbs, and do a cranial nerve examination, and that's only after taking a full history. My differential diagnosis for this patient is so this is a presentation of upper motor neuron lesion that's affecting both the motor and the sensory component. And given that there is a dermatomal level, I believe that this is a lesion in the spinal cord, and that could be due to a vascular cause, or like infarction, or it could be due to a tumor, or it could be due to a fracture, or it could be due to a demyelination lesion. And to confirm my diagnosis, I would need to take history, like I said, and complete my examination. And I'd like to get a set of observation, and I'd like to send a set of bloods, and I'd like to get an MRI, particularly an MRI spine, looking for the underlying cause ideally. And if the patient came in acutely, I'd like to alarm the neurosurgical team to manage this patient, particularly if the patient has any signs or symptoms that suggest Coda equina syndrome.
So what you will do for the patient, as you mentioned, okay?
Yeah,
Urgent MRI, right?
yeah.
How you will know it is urgent or not urgent?
So first of all, I'd like to take history from the patient. If the patient came in acutely with the,
No, without history.
I'd like to do a digital rectal exam,
Yeah.
right? And if the patient has lost the anal tone, I would be concerned about Coda equina syndrome.
Loss of sensation.
And actually, yes, loss of
anal tone.
sensation in a subtle distribution in the perianal area.
Thank you, Doctora. It is a case of spastic paraparesis with dissociated sensory loss in both lower limb with a sensory level up to L2. It is not a Coda equina. It is Conus. It is higher level than the Coda equina. Coda equina more.
Oh,
Brown
yeah, yeah.
sequence.
It is definitely higher level. It's around the L2 level, and it's not like Coda equina, but
يعني طبعا more detailed you can tell the diagnosis. It is clear يعني you have whatever you have one of the upper motor neuron خلاص it is with weakness it is spastic paraparesis. Upper motor neuron spastic paraparesis with sensory level and dissociated sensory. خلاص this is the diagnosis without feeling يعني because you will give you the examiner he will give you too much time detail. 1 minute
sorry,
for the
just
diagnosis and
just very slowly. Sorry. I'm not a neurology doctor, but you say like spastic paraparesis plus,
with sensory level.
yeah.
And then dissociated sensory loss, anterior column in the right side loss, and left and the posterior column in the left side. Most probably compressive cause there. Most
Do you
probably
think
compressive.
you mean Brown sequence syndrome? Or
No,
it's
no, no,
not?
Dr. Bassem. Conus medullaris has the same like Brown sequard, تمام? But Brown sequard it will not cause especially
Bilateral.
the ankle يعني I will tell it by another way. It is like cervical myopathy but lower level in the spinal cord. It is the same. Have L2, he will lose the ankle, the knee reflex, and he will have exaggerated ankle reflex. It is the same as cervical myopathy with compressive. So he will be at the knee level. At the knee level, it is a lower motor neuron lesion. Below the knee level, it will be upper motor neuron lesion. And if you ask the patient, this is the clue for this case. يعني this case, if you told upper motor neuron lesion in picture of spastic paraparesis with dissociated sensory, or even you not catch the sensory dissociation with a sensory level there, most probably compressive there, I need now to do an anal rectal examination and check sensation in the saddle area to see if the patient has emergent indication for surgical intervention. Most probably conus medullaris, he will come after a trauma, tumor, TB as a compressive cause, but most probably conus medullaris come with in acute care. He will come with this suddenly he can't walk, pain in his back after trauma, after sudden heavy something. If he has before know that he has a tumor or TB or the known causes of the spastic paraparesis, and he neglected, and then commonly after compression of the L2 level, he will come by this picture. Sometimes not complete by dissociated sensory loss by this, but he will sure have a spastic paraparesis with level lower motor and level higher motor like cervical myopathy. Like here, he will have knee absent and ankle hyper against the sub-combined degeneration. It will be against this. And he will have sensory level up to some patient anterior iliac spine, and he will have as mentioned, sensory level and spastic paraparesis, and he will lose his anal tone and saddle anesthesia. The differentiation between it and the con and coda equina, it will not be acute like this. He will have because it is not acute, the patient, he will have some atrophy, some fasciculation. It will be more lower motor lesion more than upper motor lesion. This coda equina. It will be very gradually, and it will take the last part of the spinal cord. So it will not have after it will not have upper motor neuron lesion. It will be mostly as a lower motor neuron lesion with severe back pain more than the coda equina. Yani the back pain in the conus medullaris. Coda equina, it will have more severe back pain because it is progressive since a long time. When he will come to you, he will be in the late stage. So the clue in this case, you can mention it is spastic paraparesis with sensory level, as usual we learn it يعني, with sensory level mostly compressive cause. طبعا there is non-compressive infection, vasculitis, infection like transmyelitis, like as we learned it يعني. But the most important here, it is emergent case. You should mention for him, I need to do now in a rectal examination and confirm by history. If there is saddle anesthesia, I need to call urgently the neurosurgeon and do MRI. Maybe you need urgent decompression for this spinal cord, especially if the patient coming acute. This is a case. Otherwise, the same MRI, a basic from the basic lab, and nerve conduction velocity, same as the neuro examination. And very good that you examine this other issue. If you didn't examine the back, he will minus you sure. يعني two thing here, he will minus. طبعا the exam technique خلاص, you very nice. They catch the signs, but without the red flag to save the patient lip and examine the back. Maybe the cause, he has some operation and this is the cause. Maybe already have done the operation and or any other cause for the operation, and this is the cause يعني for his. Besides the same non-pharmacological and pharmacological counseling, education, physiotherapy, occupational therapy, everything is the same. يعني. Okay, Dr. Basim. So the differential here,
Yes.
conus medullaris, the diagnosis, it is conus medullaris. Differentiation, it is coda equina. Then you can put the list of compressive cause of spastic paraparesis with sensory level. Dr. Basim, I finished my comment.
Okay, thank you, Dr. Muhammad. So again, the reflexes in summary, what will be hyper and what will be hypo?
Basim, this is L2 level. L2 level is the compression there, and L2. This is conus medullaris. So you will lose at the knee, then at L3, L4, at the ankle, it will be hyper. Like cervical myopathy, when we did cervical myopathy, you will lose the biceps at C5, C6, C7, C8 will be hyper at the tricep. The same as the cervical myopathy.
Okay, so you mean L4 and L5 will be lost?
لا,
the-
will be
the level-
hyper. Will be hyper. The
Lost.
level at L2.
Yeah, but the knee reflex is L3, L4.
Yes, this is what I mean. L3 and L4 will be lost.
Sorry. At L3, L4. Yeah, right.
Yeah, the knee. This is I think this is the only difference between the conus medullaris
Yes,
and
yes.
coda equina. The knee reflex will be lost.
Yes, yes.
And
Right, Dr. Bassem. At L3,
Yeah.
this is the type because coda equina away. This is the last
Yeah,
tip.
yes,
the
this
last
is what
part
I.
of
Yeah.
the- No,
Exactly.
no, يعني you will not have below the level of coda equina. خلاص, no, all the reflexes will be lost and they will
Exactly.
be like lower motor.
Yes, agree.
The
Okay,
coda
what other?
equina is a lower motor neuron presentation.
Yes, coda equina will be lower motor. So you will have lost all the reflex, the
And
ankle.
fasciculation, you will notice the fasciculation and the
Exactly.
atrophied muscle because the patient, he will take a long time. He will be for years. He will be have gradually. He feel that like some weakness by progressive. Then he will come you when خلاص he can talk.
Yes.
How likely this will appear in the exam?
Yeah, this is what I want to say also, really, Dr. Ines. It's not as common as the other manifestation or other
I
presentation.
told Dr. Basim he will not even he will bring the case coda equina or conus medullaris. He will not wait for you to tell him conus medullaris. He will wait you to give the compressive cause of compressive spinal cord, the cause of spastic paraparesis, and how you will manage acute or chronic, or how you will manage it as fast as possible. This is my case. This is the case I bring it. It is not a case of base, يعني not appeared before the conus medullaris. But I think coda equina appeared, I think, before.
Yes, okay. As a lower motor neuron lesion, you can put it as a differential, but it will not be as a clear and straightforward case. This is a coda equina. You can put them as differential. I don't know if they brought it before in any center. Actually, I'm
I'm
not
not
sure.
sure, but many mentors and many يعني recalls mentioned that there is a Kodak. They mentioned that we should know about Kodak equina.
Yes, you should know it, but again, it will not be the first differential because this is a case of surgery intervention. Patient should be underwent the surgery immediately. Both of them. By the way, coda equina also can cause severe pain because of the nerve
It's more
compression.
severe pain. It is more severe pain. The Kodak
Yes.
equina more than the Conus medullaris because
Yes,
too much progressive too long time.
exactly. And I remember as a practical case, I saw one of these cases, and the neurosurgery took him to the OR immediately once
Yes.
the patient was diagnosed.
Yes,
Because
Conus medullaris urgent medical emergency.
Yeah.
يعني if he will bring it in exam, he will not bring it as a case. He will bring candidate or someone have spastic paraparesis, and he will put on it lost reflex knee and and exaggerated ankle with some sensory level. He will tell you, but wait you. This is mean there is a level compressed in the spinal cord. He will wait you to tell whatever that he need emergency intervention. It's a medical emergency.
Yeah, the medical here will be steroid. You should mention steroid
Yes.
to relieve the compression or the
Yes,
edema
definitely.
around
Yes,
the nerve, the spinal cord.
Right. Yes.
Okay. Again, let's summarize the difference between coda equina and conus medullaris. It can come as differential between upper and lower motor neuron lesion in the leg. And by the way, you can find both of them, upper and lower. You can have both condition, and you can put it as a differential to mixed upper and lower motor neuron lesion. Okay, let's talk about them quickly. How the differences started from the tone, as Dr. Muhammad mentioned, hypertonia, hyperreflexia, and hypertonia, hyperreflexia in the conus medullaris as upper motor neuron lesion, and the hypotonia, hyperreflexia in the coda equina. What else will be there? The sensation. Sensation affection, saddle area, will be affected in the coda equina. So the patient will feel numbness in the saddle area. And it's very important difference, which is absent in the conus medullaris. The other thing will be positive in conus medullaris and absent in coda equina will be the knee reflex. Knee reflex will be absent in the conus medullaris, and the ankle reflex will be hyper or exaggerated in the conus medullaris again. However, in the coda equina,
both
all
affected.
reflexes will be lost.
Yes.
So the difference in the ankle will be preserved in the conus medullaris, and it will be lost in the coda equina. As Dr. Muhammad mentioned, the underlying cause will be, for example, something or compression in the conus medullaris, and for the coda equina will be surgical cause need to be taken to OR for surgery.
Sorry, can I just clarify? So,
Yes, sure.
where do you expect a sudden loss of sensation? In which of these?
Loss of saddle area with the coda equina.
No,
And
both, Dr. Bassem, both will be affected. Both will be affected.
I think more with one of them, which is which is coda equina. What else also positive, Dr. Muhammad and Dr. Inas? The anal tone. Yes, the anal tone will be affected more with the conus medullaris.
I think the other way around.
Okay, if you can have the schedule.
I remember when I worked in AD,
Yeah.
we used to test if the patient has coda equina or not by doing a PR exam. And if there is no anal tone, this goes with the coda equina. But maybe I'm wrong. I haven't done this in ages. I'm not sure.
Okay, let me check the photo. I have image for that. Give me a second.
I send it to you comparison, Dr. Bassem, between them from the Medscape.
Okay, I will share it here. Give me a second.
في one very anal more and one saddle as a general more.
Okay, I'm sharing them to the chat box, or everyone can see it. Just a second. Here it is. Yes, conus medullaris, presentation sudden and bilateral, coda equina gradual and unilateral. Reflexes knee jerk preserved, but ankle jerk affected in conus medullaris, and coda equina both are affected or lost. Radicular pain less severe in conus medullaris and more severe in coda equina. Low back pain more with the conus medullaris, less in the coda equina. Sensory affection, numbness tends to be more localized to perianal area symmetrically and bilaterally. Sensory dissociation occurs. Numbness tends to be more localized to the saddle area, asymmetrical, maybe unilateral, no sensory dissociation, loss of sensation in specific dermatome. Perianal and saddle areas, you can see it, Dr. Inas. So the saddle area will be with the coda equina, as I mentioned, but perianal and the conus medullaris. Okay?
Yeah.
Yeah. The power, the strength, typically symmetrical hyperreflexic distal paresis of the lower limbs, that is less marked fasciculation may be present. In conus medullaris, asymmetric, areflexic, paraplegic, then is more marked. Fasciculation is rare, atrophy more common. So we summarize. You have to know the difference, but both of them are similar in certain points, but you have to know the most important difference, like the sensation and the jerks and the reflexes, I mean. Okay? Clear now for all? I think this image summarizes the difference between both. Is it clear for all? Dr. Inas, clear for you?
Yes, thank you. Yeah.
Okay. It's
So
as it's
mainly like more of a
yeah,
lower motor neuron presentation with
exactly.
fasciculation
Yeah,
and change in the sensation within the whole saddle area.
exactly. This is
Conus
what could I call.
medullaris upper
Yeah,
motor neuron presentation, more of just the perianal area.
exactly. Yes, this is in summary. Yes, as you're right.
So the anal tone in the
Yeah, in
conus
Conus Medullaris.
that you are, it is emergency to test it and check it
Yes,
for if there is like this. Yeah, على طول if you lost surgical intervention immediately.
exactly. Remember always the saddle area is the area down, but the perianal may be higher, and this is the level of also conus medullaris, which is higher than the area of coda equina. The saddle area always down, right? The inner
I
saddle or the
understand.
thigh.
My
Yeah.
understanding is the saddle area is the perianal area, the inner
No, no, no.
thighs.
The perineum.
Yeah,
Perineum and the
exactly.
thigh
The whole
inside.
perineum, yes.
Yeah, exactly. This is
Saddle that you are in the horse. This is the
exactly.
area
Yes.
fitting. But
Yes.
anal is the last area plus.
Exactly.
Yeah, exactly. Very
Yes.
well explained, yes.
Perfect. So this is the take-home message from our case today as a neuro. However, don't worry, it's not very common. I can say even it's not common. There is or there are a lot of common cases which can appear more than this case actually. So if you are preparing for PACEs as a neuro or nervous station, do the cranial nerve examination, do the Parkinson, do the upper hand and the proximal myopathy, distal myopathy or distal weakness, and do the upper hand, upper limb, lower limb. The last thing to do, this topic, the conus medullaris and coda equina. Yes, I know it's not that much common, but at least read it once. This is schedule, summarize everything for you. You can read it once only before the exam. Okay? Anyone has a question or doubt?
I have one question, but it's not
Yeah.
related to today's discussion. I think if you can, if you're in a hurry and you need to leave this meeting, it's absolutely fine. But I would appreciate guidance on if the patient came in with a proximal weakness, the focus would be mainly on the myotonias, right?
Yeah, first of all, it's the time to discuss everything you want, your exam next week, I think. So no matter to end the meeting or no. Whatever you want, please discuss.
Thank you. I really appreciate it.
No worries, Dr. Inas. Okay, let's talk about proximal myopathy. Yes, it might come as myotonic dystrophy. Okay, I agree it will be the case there. But when to say it? When to say this is myotonic dystrophy patient? When to say other causes, like for example, endocrinology causes or rheumatological causes or medication causes. What do you think the major difference between the myotonia dystrophica and the other causes of proximal myopathy?
I think the patient's look, he will look like bilateral ptosis, baldness, wasting of the temporal
Perfect. So
area.
you will have the features of myotonia dystrophica. This is the first major difference. You from the face itself, you will know this is long haggard face. This is myotonic patient. What else? Very major point.
The gait, they would have like high stepping gait.
No. It's not high stepping. In the proximal myopathy, it will be waddling gait.
Oh yes, but I thought in myotonia dystrophy they would have distal, no?
There is
Distal.
two types. There is two types, by the way. There is two types in myotonia dystrophica. Type 1, which is distal. Type 2, which is proximal. And the
I
most
see.
common is the distal one. But
I've
we are
seen
talking
distal actually.
about the proximal one. Okay, the
Okay.
proximal myopathy. Let's continue our discussion. What are the major difference between proximal myopathy and myotonia or limb girdle or facioscapulohumeral dystrophy? What do you think? The Duchenne, the Becker, what's the major difference between this group of disease and the endocrinology cause or rheumatological cause?
Maybe the muscle weakness is more than the other endocrinology or rheumatological causes.
Yes, you will have dystrophy, means wasting of the proximal muscle.
I see. Yeah.
Yeah.
Okay.
What else? It's a very important point you have to mention. since you see this patient as, what do you think the group, the age group of those patients? The Becker, the myotonia,
So
the
very
limb.
unlikely to see Duchenne because they would die before the age of 20.
Okay, forget about Duchenne. We are talking about other. What do you think is important in the group age?
I think the myotonia dystrophica tend to become like 30 to 50 years, for example.
So young
Yeah,
patients, right?
yeah.
You are talking about genetic condition. So
Yes.
you are saying, I can see this is young gentleman. So I could think this is a case of, for example, congenital dystrophy case, right?
Yeah.
Agree for that? What
Yes.
about the others? Yes, it could be young, but commonly they will be elderly,
Yeah.
little
Oh,
bit.
yes, yes.
The
Yeah.
family history, you can add to your history. I would like to take family history from this patient.
Yeah.
What about the medication? The medication can affect every age, but most of the patient taking medication, usually they are middle age, right?
Yeah.
So the major difference, the age group. Once I have young patient, I can say this is genetic or congenital condition. So you can give the differential of genetic. Limb girdle, as I said, and fascioscapular humeral dystrophy, along with myotonia dystrophica type, the type 2 proximal one. And what else? I mean, you can see also myasthenia gravis, right? It
Myasthenia
can be,
gravis, yeah.
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 Okay, these as a genetic or congenital causes. Then you can
Yeah.
speak about endocrinology causes,
And
hyperthyroidism, hyperthyroidism, acromegaly, and you
okay.
can talk about rheumatological cause, SLE, dermatomyositis, and so on. The drug or medication cause, you can speak about steroid and statin. Cushing as well, also one of the endocrinological
Yeah.
cause. That's it. So it's and the gate will be, as you said, pathognomonic
Waddling.
waddling gate.
Waddling. Yeah. And
Yes.
I have another question,
Yeah, sure.
if you don't mind.
No more.
So if we've had a case of Charcot-Marie tooth, which is
Yeah.
hereditary sensory motor peripheral
Yes.
neuropathy, and like you've seen the classic, like a Charcot-Marie tooth, and you knew that it's Charcot-Marie tooth, and you've been asked for differential diagnosis,
Yeah.
would you mention diabetes peripheral neuropathy as one of differential, or would you focus on the motor predominant sensory motor peripheral neuropathy like lead poisoning or porphyria? And I'm asking this question because some of my friends got trapped when they mentioned that my differential diagnosis is porphyria or lead poisoning, and the examiner said like, "Oh, yalla, what is lead poisoning? Tell me about lead poisoning," and all
Yes.
of that.
I agree.
Other people would just mention diabetic neuropathy, although diabetes is sensory predominant sensory motor peripheral
Yeah.
neuropathy. If you see what I mean.
Yes, I got you. Okay. If we speak about the incidence, how much you see in your life a case of lead poisoning compared to
I don't.
diabetic?
Yeah, I don't think I'm gonna.
Plus, yeah, add to that. Do you think is it sensory with the lead poisoning? It causes sensory loss or peripheral neuropathy,
I
or it
think it's
causes
good
motor neuropathy?
because motor predominant sensory motor.
Exactly. Yeah, it's motor more.
Yeah,
So
but a Charcot-Marie tooth is sensory and motor, but predominantly motor, no?
hereditary sensory motor. Yes, I agree. But if you want to talk about peripheral neuropathy, you are talking more to the sensory predominant one. The motor will be another differential as motor predominant. We are talking about sensory predominant, right? Plus, as I
A
said, the
Charcot-Marie tooth is motor predominant, no?
it's sensory.
Is it?
There is two types actually. There is two types. There is type 1 and type 2 also.
I see. Okay. I
Yeah.
thought it's motor predominant.
No, I remember there is two types, and type 1 I think is sensory or axonal, and the sorry, type 2 axonal, and type 1 is demyelinating. But to be honest, which is the predominant? I think sensory more, if I'm not mistakenly saying that. Anyway, what we used to say as a differential to hereditary sensory motor neuropathy
Mhm.
usually start again with the genetic disease. Okay, start with the genetic or congenital causes.
Like,
For example, yeah, as you said here, Charcot-Marie tooth, and you don't say Charcot-Marie tooth, say the hereditary sensory motor neuropathy first. Okay.
oh, I see. Okay.
What else? Other type or other major type or classification. So congenital and acquired, right? Always start in this way of classification. Don't mention every disease only. So start as a systematic answer. What I know, I have congenital type and acquired type. The congenital type, you can say what we mentioned. What else you can say as a congenital one?
There must be a lot of syndromes, but so is it like
Okay, let's go to the acquired one. I cannot recall the second congenital one, but let's go to the acquired one. If you start with the congenital, you finish the hereditary sensory motor. Now you will say the acquired one. What are the common cause of acquired sensory motor neuropathy?
okay, yeah, like diabetes is one of the
Yes,
common
you have to
causes.
start with diabetes. What else?
Alcohol, metabolic,
Exactly.
vitamin deficiency,
Yes, alcohol, disease, toxins,
yeah,
medication,
paraneoplastic, yeah, drugs, CIDP.
paranoia. So always give as classification or as systematic and terms, not as a disease. Yes, you can say the diabetes. Of course, I agree to mention it in the top of them. But after diabetes, what you can say? You can say toxins. What example of toxins?
Alcohol,
Alcohol, exactly, on the top of them.
chemotherapeutic agents.
Chemotherapy, you can mention here, or with a drug,
Yeah.
right? What are the drugs can cause peripheral neuropathy?
I think chemotherapy, carbocysteine, or
Yes, perfect. What else?
the
Metronidazole, nitrofurantoin,
yes,
right?
and isoniazide.
Isoniazide, perfect. You finish the drug. The disease. What disease you are know, and it can cause peripheral neuropathy.
Like inflammatory conditions like rheumatoid, SLE, vasculitis,
Perfect. All this can cause. Plus HIV. Don't forget the HIV.
HIV infections. Yeah.
Yeah, so by systemizing the answer, you can give a lot of example.
But it's
Rather
not a
than
problem to say like these are my differential for what I thought it's a Charcot-Marie-Tooth.
yes, but don't
Okay.
start saying lead and porphyria cutanea tarda in the top of your differential.
Oh yes, yeah. I think this is what my friend got trapped
Yeah,
in.
I think that's why the examiner was angry. It's a matter of common differential, not only giving differential. Yes, you are reading, you are studying, but you are not putting your clinical sense. You have to
Exactly.
use your clinical sense and the experience. What about your experiences in your practice? Is it lead poisoning you are seeing every day or diabetic neuropathy?
Yeah, diabetic. And so
Okay.
it's common for diabetic neuropathy to appear as motor and sensory.
Yes, it can. Yes, of course.
Okay.
Okay.
Yeah. That
And
makes
other
sense.
question?
No, that's it. I'm really grateful. Thank you very, very much. My exam is on Saturday. I'll update you on Saturday how it
Oh
goes.
my God. So this is the last session with us.
Yeah, inshallah. Inshallah.
Hopefully, I heard and I really, I was happy to hear good news from most of candidate practice here the day or 2 weeks even before the exam. Particularly in UK, I don't know what the difference, but I think maybe in UK they are little bit benign and listening
Really?
to really yes. I believe it's the rate in passing rate in UK for the people who's living in UK. So don't tell me as overseas candidate went to UK and he passed easily because he doesn't know what they are talking about, what is the system, how they are thinking. But you know what the examiner is thinking now because you work with them.
But do you know, like, there is a difference between the pass rate for people of color compared to white people in the UK?
It depends on the center, I think.
Yes,
So
it depends on the center, yeah.
yeah, what's your center?
Fairfield, north of Manchester. But I'm not aware of anyone did the exam there, so I'm not sure.
Anyway, be confident, calm down, take a breath before answering, be systematic, don't rush to answer, and start to give the answer in a systematic way. Don't stay just medication. This is our mistake, by the way. Whenever you are thinking how to manage, you are thinking about the pharmacological part. but this
Yeah.
is not the matter. The matter how to be systemized in the answer. Start to say, as you said today, multidisciplinary team. They are happy if you start the answer with this. What after that? You can mention the team members, or you can start the non-pharmacological. They are also being happy when they hear the non-pharmacological. Like he will tell you what, like what, doctor. So you can say a lot of things which can help the patient. Even he will not take the medication if he follow what we call it lifestyle modification. For example, okay, control your diet, your exercise, all these things can give you healthy life, right? And it will
Yeah.
help any patient. Or postural drainage for bronchiectasis, for example.
Yeah.
Avoid alcohol, avoid smoking, or stop smoking in some conditions, like COPD. The examiner will
Yeah.
be happy to mention
Yeah.
stop smoking in the top of your management plan. You
Yeah.
cannot say for COPD, I will start inhaler. Okay,
Yeah.
I don't need inhaler. What the most important to stop progression of the disease, to stop smoking, right?
Yeah.
And so on.
And this is actually what happens in real life, to be honest.
Yes, I think, yes, this is our real life practice.
Yeah.
The screening, they like when you mention the genetic team or the genetic screening or family screening. Whenever you have condition which is running in families, you can do initially the family screening. Why? Because you can prevent complication might happen with certain family members, like HOCM. Okay,
Yeah.
it's very important to mention the genetic screening. So please, before answering, take a breath and always
I
calm
think.
down. And we will pray for you.
Please,
Yes,
everyone, please,
don't worry,
shukran.
Dr. Nas.
Thank you very,
We
very,
also.
very much.
Please
All the best,
try
everyone. Thank
to
you.
minimize your jargons.
I will.
Okay,
Yes. Okay.
jargons. It's very dangerous.
Okay. I will. I
Okay,
promise. I
use
promise.
always simple way while explaining. Be
Okay.
simple as much as you can.
Okay. Inshallah.
Okay.
Inshallah. 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 Thank you.
Okay.
Thank you.
We'll
Thank
pray
you.
for you.
Mashallah.
Good luck and
Inshallah.
best of luck, Dr. Inas.
Shukran. Shukran. Shukran.
You can
Barakallah
give
feek.
us feedback if you
I will
have
do.
time, of
I will
course.
do.
Yes, we will wait for you. You are most
Inshallah.
than welcome to have another always to be visiting or even
Inshallah.
commenting. Okay. Yes.
Inshallah. Shukran. Shukran. تحياتي. مع
That's good.
السلامة. شكرا.
Okay. Okay. Good luck, Dr. Inas. Okay. Thank you, Dr. Inas, for this good revision quickly. Best of luck, all of us praying for you. All of the best. Dr. Ala, I will be really appreciate if you put guidance how to start preparing for paces from zero. Yes, Dr. Ala, we can do it in a day, maybe next week. I can do it from zero. But what I believe on, the YouTube channel has a lot of videos. You can anytime visit and hear, and you will know what you are doing and what you are studying in paces. Okay, so it's a matter of to know what the station are and how to prepare every station. There is two or three types of station: the long clinical, the short as a clinical we are doing today, and the communication as we did yesterday. And by the way, we are doing all the station every day, every week, so you will never miss how to do the approach. Start to attend from now onwards. You will know everything. Next week, we will do two sessions, long clinical and communication, alternatively till the end of the week. The next week, we will do long clinical, communication, and short clinical station. And these are the station in the exam. Okay, you will not miss any of them. Any day you can visit the YouTube channel, you can listen, you will know how the discussion will go, what they are asking, what to do, what to present, how to present, what the question will be, investigation, differential diagnosis, the management plan, everything in the YouTube channel. Just have a look. Day after day, you will know what are the stations. If you want again to speak, it's okay. Maybe on the Saturday, we can have an open discussion at the end of the session, or maybe on the Sunday, according to the time of the session. Okay. But today, actually, because of the weekend, I don't want to make it more lengthy than this, but I believe we will repeat it again, Dr. Ala. Don't worry about that, okay? Yeah, no worry, Dr. Ala. By the way, there is also short videos about, I shared it in the group a couple of days ago. How to counsel, how to explain, how to break bad news, when to break bad news. There is short videos. It takes only a couple of minutes. You can hear and you can understand what we are talking about. Okay? Just visit the YouTube channel. You will have, I think, more than months, maybe almost 1 year. But it's okay. You can roll quickly and you can see the short videos. It will be guide you regarding the main task or the main station, the main idea of the station. Okay, you can message me privately, Dr. Ala, if you want more details. I can send you to you the most important videos. Okay. Thank you, everyone. Thank you, Dr. Muhammad, Dr. Inas. Best of luck. Dr. Inas will pray for you. Hopefully, you will pass this exam. Just some of the confidence, and believe me, you will do it. Thanks, everyone, for the attendance today. See you, inshallah, in the next day. Have a nice weekend. Good luck on night. Assalamu alaikum wa rahmatullahi wa barakatuh.